Good afternoon. This video was created for NUR 678 Advanced Health Assessment for the differential diagnosis of chest pain as well as the interpretation of cardiac biomarkers. Chest pain is a very common complaint. Many patients are well aware that it is a warning of potential life-threatening disorders and seek evaluation for minimal symptoms. All the patients, including many with serious disease, minimize or ignore its warning. Pain perception, both character and severity, varies greatly between individuals as well as between men and women. However, described chest pain should never be dismissed without an explanation of its cause. Relevant to the pathophysiology of chest pain, the heart, lungs, esophagus, and great vessels provide afferent visceral input through the same thoracic autonomic ganglia. A painful stimulus in these organs is typically perceived as originating in the chest, but because afferent nerve fibers overlap in the dorsal ganglia, thoracic pain may also be felt as refer pain, anywhere between the umbilicus and the ear, including even the upper extremities. Painful stimuli from thoracic organs can cause discomfort, described by some patients as pressure, tearing, gas with the urge to eructate, indigestion, burning, aching, stabbing, and some of the patients describe this type of pain as sharp, needle-like pain. Although this is very much described as neuropathic, there is a high nerve innervation at the level of the autonomic visceral input, therefore is also felt by some patients as such. When the sensation is visceral in origin, many patients deny that they're having pain and insist that it's merely a discomfort. Etiology of chest pain. Many disorders cause chest pain or discomfort. These disorders may involve the cardiovascular, gastrointestinal, pulmonary, neurologic, or even musculoskeletal. In this slide, we are describing some disorders that are immediately life-threatening that should be recognized first as soon as the patient arrives with chest pain. These include acute coronary syndrome, such as acute myocardial infarction or unstable angina, thoracic aortic dissection, tension pneumothorax, esophageal rupture, and pulmonary embolism. Now, next slide, we're going to go through the most pertinent symptoms that differentiate each of these. In the case of myocardial ischemia, such as acute myocardial infarction and unstable angina, the pain is described by some patients as acute, crushing pain radiating to the jaw or arm. It could be the left arm, the right arm. The pain is with exertion and is relieved by rest, such as angina pectoris. Some patients have an S4, as you already know, ventricular gallop. Some times patients on physical examination have systolic murmurs of mitral regurgitation. To be able to diagnose myocardial infarction, you know that relevant diagnostic tests would be serial EKGs, cardiac markers, such as troponin I, creatine kinase, isoenzyme MB, for myocardial isoenzyme, which is more specific for skeletal muscle. as well as you could do BMP, you could do ESR, you could do myoglobin, and many other cardiac enzymes that we will discuss later. In addition, a patient should have a stress test or CT angiogram to rule out other diagnostic evaluations provided for life-threatening situations. Often, patients undergo cardiac catheterization and coronary angiography. I would like to stress also that some of patients that have myocardial infarction and unstable angina present with certain findings that raise suspicion of more serious etiology of chest pain, which are called by the Cardiac American Association as red flags. And these are abnormal vital signs such as tachycardia, bradycardia, tachypnea, hypotension, signs or symptoms of hypoperfusion such as confusion, diaphoresis, shortness of breath, asymmetric breath sounds or pulses, for example, in the patient that have tension pneumothorax, asymmetric breath sounds, as I said, a new development of heart murmurs, and also pulsus paradoxus, which you would see that is present in patients with thoracic aortic dissection and some other disease process that are they're not life-threatening etiologies such as thoracic aortic aneurysm dissection. This pulsus paradoxus was already discussed on differential diagnosis of cardiac conditions during the cardiac assessment class. And remember that pulsus paradoxus is a drop of 10 millimeters of mercury or more during inspiration, which is completely abnormal and is present not only in thoracic aortic dissection, but also in cardiac tamponade, pericarditis, myocarditis, and as well as obstructive sleep apnea syndrome and pulmonary emboli. The pain for thoracic aortic dissection is described sometimes by patients with a sudden tearing pain radiating to the back. Sometimes patients present with syncope, stroke, or leg ischemia. Remember that blood pressure and pulse are unequal in extremities. Very common for this condition, as well as coarctation of the aorta for pediatric population. Patients most of the time have a history of hypertension and they're older than 55 years old. How to diagnose that thoracic dissection besides these suggestive findings? With chest x-ray, most likely patient present with widening of the mediastinum. You could do a CT scan to confirm the diagnosis, and even transesophageal echocardiogram will also reveal the pericardial effusion. Sometimes when the blood leaks into the pericardium, patients also present not only with sudden tearing pain radiating to the back, but also signs and symptoms of pericarditis and cardiac tamponade, which would be mostly pleuritic chest pain, which is sharp in nature, worse in inspiration and cough, as well as is worse when the patient lays back, and is better when the patient sits up straight and leans forward. When the patient gets complicated with thoracic aortic dissection and cardiac tamponade, not only they would have hemodynamic instability with hypotension and tachycardia, but also they would have muffled heart sounds. For tension pneumothorax, patients present most commonly with sudden severe pain, pleuritic as well. They have asymmetric chest expansion. They're hemodynamically unstable since the mediastinum and vessels are shifted to the contralateral side of the pneumothorax, impeding venous return and preload, and therefore compromising cardiac output. Therefore, patients could collapse. They could come with a syncope episode. They could present with cardiac arrest as well, or less severe scenarios such as hypotension and tachycardia. Patients with esophageal rupture, they present with sudden severe pain following retching, vomiting, or instrumentation such as iatrogenic esophagogastroscopy, EGD, transesophageal echocardiogram. On physical examination, patients would present with subcutaneous crepitus detected by palpation of the chest wall as well as auscultation. These patients also would present with red flag findings as previously discussed, such as hypotension, tachycardia. They also have signs and symptoms of hypoperfusion, shortness of breath, and pulsus paradoxus. Diagnostic approach for these patients is visible with the chest x-ray, as well as esophagography with water-soluble contrast for confirmation. This is a basic understanding of differential diagnosis. Once you go to your specialty areas such as family and acute care, we will go in detail of all the chest x-ray findings and echocardiogram results and diagnostic approach, in addition to, as well as specific therapy for it. Besides life-threatening situations, differential diagnosis for pericarditis also includes, differential diagnosis for chest pain also includes pericarditis, myocarditis, chest wall disorders, such as those involving muscles, ribs, or cartilage. For example, a rib fracture, or costochondritis, etc. In addition, we will discuss several pleural disorders giving pleuritic chest pain, GI disorders such as gastroesophageal reflux disease, cholelithiasis, and an example of an idiopathic chest pain as well. Patients with pericarditis most commonly present with a constant or intermittent sharp pain, often aggravated by breathing, such as I explained before. This is a pleuritic type of pain, even though it's not related to the pleura. It's a serosa, and the serosa is basically a layer of sheath that covers all the main organs, such as the pericardium, the pleura, the peritoneum, etc. So when this serosa is inflamed, regardless of location, it would give you a pleuritic sharp pain that it does variates with position and breathing. So for pericarditis, the pain is aggravated by inspiration, by swallowing food, by being supine, and is relieved by sitting and leaning forward. In addition, patients upon physical examination, they would have pericardial friction rub, um, presence of jugular vein distension. If you do an EKG on these patients, they would have a throughout elevation of ST segment, so ST segment elevation throughout the EKG, which at glance you might think is a myocardial infarction, but it is impossible to have an infarction on all the walls of the heart at the same time. And this is because the pericardium, which involves the whole heart and all the walls, is inflamed. This is the reason why there is ST segment elevation throughout. Also, troponins could be elevated, but it's a minimal elevation because the myocardium itself is not damaged. It's the pericardium, and the CPK level is normal. Diagnosis, besides clinical signs and symptoms and EKG findings, could be demonstrated by a transthoracic echocardiogram. Patients with myocarditis, the pain is stabbing. It could be constant, often associated with pericarditis, so it would mimic exactly the same symptoms of pericarditis. Patients have associated fever, dyspnea, fatigue. They have a history, most likely, of a recent viral infection. These patients would have elevated serum cardiac markers. The erythrocyte sedimentation rate is elevated, as well as the C-reactive protein. Those are inflammatory markers, which are positive in myocarditis. And diagnosis is usually by an echocardiography. Now, the discussion for pleural disorders could include from the life-threatening conditions already discussed of pulmonary embolism and tension pneumothorax, and also includes pneumonia, pleuritis, and even any disease process that is attached or very close to the pleural space that would give an inflammatory condition enough to irritate the pleura. It would produce exactly the same symptoms. And when I say this, it could be a scarring at the level of the pleura. It could be a tumor attached to the pleural space. It could be even an instrumentation after chest tube placement. Anything that irritates the pleura would give you exactly the same quality of pain for pleural disorders. And this one is, as already described before, a pleuritic in nature type of pain, which is sharp and is worse in inspiration and cough. Examples of gastrointestinal disorders would be gastroesophageal reflux disease. And the pain for gastroesophageal reflux disease, already discussed in the pathophysiology and pharmacology, is burning type of pain located at the level of the epigastrium. It could be radiating through the throat. Patient feels the burning sensation exacerbated by bending down or laying down flat, and is relieved by food or antacid. If we discuss in details, for example, peptic ulcer disease, this is a recurrent vague epigastric pain with a right upper quadrant discomfort. In a patient that have risk factors such as smoking, uses alcohol, is relieved by food and antacids or both, which is completely different in gastric ulcers. Remember, that is aggravated by food and antacids. Diagnostic approach for patients that have gastroesophageal reflux disease as well as peptic ulcer disease would include, besides the clinical evaluation, an endoscopy, and also remember Helicobacter pylori for peptic ulcer disease, which is the most common etiology. If we want to discuss even further pancreatitis, the pain is in the epigastrium, in the lower chest as well, and is radiating to the back, to the upper scapula. It's worse when laying flat and is relieved by leaning forward as well. But it's associated with vomiting. And pancreatitis, remember, that has a lot of capillary leakage. Patients develop hypovolemia. They could go into shock. They could have a history of hypertriglyceridemia, biliary tract disease, alcohol abuse, and diagnostic confirmation is by elevated serum lipase and abdominal CT. Now, in gastrointestinal, for the assessment of the abdomen, we will discuss differential diagnosis of biliary tract disease with other conditions associated with the GI tract. Idiopathic, an example of this one would be herpes zoster infection. Many patients come in without the actual vesicular rash, and it basically appears after the patient is hospitalized. But when they come through the ER or they go to an outpatient facility or office, they only come with a sharp band-like pain in the mid-thorax unilaterally, because remember, this pain does not cross the midline. And 3 to 4 days after, the rash appears and is linear and is vesicularly appearance rash. But it's very much confused with cardiac disorders for chest pain. Now, how do you evaluate this patient? Remember that in health assessment, you have to go through the history, review of systems, past medical history, as well as physical examination. In the history of the presenting illness, you should know the location, duration, character, and quality of the pain. The patient should be asked about any precipitant events, such as straining or overuse of chest muscles, or which type of activity were you doing that could have exacerbated this pain. As well, you should ask any triggering or relieving factors. Specific factors to note include whether the pain is present during exertion or at rest, any physiological or psychological stress that you have gone through, whether the pain occurs during respiration or coughing, do you have any difficulty swallowing, any relationship to meals, any type of position that relieves or exacerbates the pain, such as laying flat or leaning forward, or inspiring or coughing. Also, previous similar episodes, have you experienced this chest pain before? Any circumstances that should be noted with attention to the similarly and or lack thereof. For example, if you receive a patient that has epigastric pain and he was actually admitted with myocardial infarction 2 years ago, and now he presents with the same epigastric pain and similar associated symptoms, I'm sure this patient is going to tell you that it might not be a myocardial infarction, but 2 years ago when I had this epigastric pain, I had an MI, so I was really worried that I'm having a second. Important associated symptoms to seek include dyspnea, palpitations, syncope, diaphoresis, nausea, vomiting, cough, fever, chills. In the review of systems, you should seek symptoms for possible causes, including leg pain, any swelling. For example, if you're trying to rule out the possibility of a pulmonary emboli, you have to ask the patient, any swelling on your extremities, any pain, any tenderness, any tingling sensation, If it's related to you're trying to rule out the possibilities of heart failure associated with angina, unstable, or myocardial infarction, any chronic weakness, uh, the same, any peripheral edema, any changes in weight, any associated shortness of breath, any congested cough, is this cough productive or non-productive, etc. Past medical history, you should document known causes, particularly cardiovascular and GI disorders, or any cardiac investigations or procedures that have already been done, or in the past. For example, this patient already had a stress test, which are the results, any prior catheterization, any prior coronary stent, risk factors such as coronary artery disease, hypertension, hyperlipidemia, diabetes, that puts the patient at risk for cardiovascular disorders. Any stroke, any tobacco abuse. For example, if you're thinking about pulmonary emboli, any recent surgery, any recent immobilization, any non-hypercoagulability state, etc. Drug history is also important. You should note the use of drugs that can trigger coronary artery spasm. And these are relevant for toxicology. Social history, you should request if the patient is on any drug, illicit drug abuse, such as cocaine. Cocaine is a potent vasoconstrictor, and remember, it gives you ischemia, coronary ischemia. So patients with cocaine abuse, as well as triptans for migraine headache, or phosphodiesterase inhibitors, and even phosphodiesterase inhibitors 5, that they're not vasoconstrictors such as sildenafil, Viagra. This is an example. It gives you hypotension and therefore decreasing cardiac output and providing ischemia to patients that are already concomitant to other vasodilators, not even including the use of nitroglycerin, which is absolutely contraindicated. You should also ask, are you on any NSAIDs? For example, if you're thinking that this chest pain located in the epigastrium is associated with peptic ulcer disease, the use of NSAIDs could trigger this condition. Family history as well should be noted if the patient has a family history of myocardial infarction, and even more important, when family died at an early age, and this is before 40 years old, as well as hyperlipidemia. Lastly, physical examination. You should document vital signs, weight, BMI. When you take pulses and blood pressure, it should be on both arms. You should differentiate if the patient has pulsus paradoxus and measure it. General appearance, if the patient has pallor, diaphoresis, cyanosis, anxiety, which anxiety is also an idiopathic cause of chest pain. Patients hyperventilate and they have respiratory alkalosis, and this provides chest pain, and it's completely atypical because cardiac enzymes are normal, EKG is normal, echocardiography is normal, but this is a diagnosis of exclusion when all the major life-threatening situations have been ruled out. You should inspect the neck for venous jugular distension, for hepatojugular reflux that you will learn now in the assessment of the abdomen. Palpate carotid pulses if the patient has any lymphadenopathy, any thyroid abnormality. Auscultate the neck for bruits. Lungs are also should be inspected for asymmetry, per cost, for the presence of hyperresonancy in a pulmonary, a pneumothorax. If the patient has any type of congestion, like inspiratory rails, you must think about CHF or pleural effusions. You will learn this in health assessment of respiratory any pleural friction rubs for pleuritis. Cardiac examination, that we should stress this part because you already went through cardiac. Know the intensity and timing of the sounds, S1, S2, if the patient has the presence of abnormal heart sounds such as an S3 or an S4, any snaps of the mitral apparatus, any pericardial friction rubs, any murmurs, any gallops. When murmurs are detected, you should try to correlate them with timing, duration, shape, intensity, any type of movement that exacerbates the murmur. For example, squatting or Valsalva maneuver. Is it heard better when the patient is forced expiring or when the patient holds breath? Differentiation should be made also between the fourth heart sound S4, which is often present in diastolic dysfunction or myocardial ischemia, or S3, which is present with systolic dysfunction. The chest is inspected for skin lesions such as herpes zoster infection, any crepitancy suggesting subcutaneous air, if you're thinking about a pneumothorax or esophageal rupture. The abdomen should also be palpated because remember, you're trying to rule out GI etiologies as well. The legs should also be inspected for arterial pulses. Palpating arterial pulses. Look for perfusion, edema, varicose veins, any presence that is suggesting DVT, such as swelling, erythema, and tenderness. And here listed at the bottom of this slide is the red flags that I already mentioned in the prior discussion of differential diagnosis of life-threatening situations. Now, how do you interpret all the data that has been collected? Symptoms and signs of thoracic disorders vary greatly, and some of them are serious, some others are not as serious, some other conditions overlap. Although the red flag findings indicate a high likelihood of serious diseases, and many disorders have classic manifestations, many patients who have serious illness do not present with these classic symptoms. Remember, we hope that it's textbook, but some patients, for example, that have myocardial ischemia may complain only of an indigestion or have tenderness on the chest wall on palpation. A high index of suspicion is important when evaluating the patient with chest pain. Nonetheless, some distinctions and generalizations are possible. For example, in the duration of the pain can provide clues to the severity of the disorder. Long-standing pains for weeks or months is not a manifestation of a disorder that is immediately life-threatening. Pain, for example, that is originating musculoskeletal would give you these findings. Similarly, patients that have a brief, less than 5 seconds sharp, intermittent pain rarely results from serious disorders as well. Serious disorders typically manifest lasting minutes to hours, although episodes may be recurrent. For example, patients with unstable angina may cause several bouts of pain over 1 or more days, but this is rare. The age also differentiates chest pain. Chest pain in children and young adults less than 30 years old is less likely to result from myocardial ischemia, although an MI can occur in these people as well if they're using, for example, cocaine. Musculoskeletal and pulmonary disorders are common causes in this age group. Exacerbation and relief should be important to describe. Symptoms are also helpful in evaluating chest pain. Although angina can be felt anywhere between the ears and the umbilical, and often not in the chest, it is typically consistent, related to physical or emotional stress. Patients do not experience angina from climbing one flight of stairs one day and tolerate 3 flights the next day. Nocturnal angina is characteristic of acute coronary syndromes, heart failure, and coronary artery spasm. Patients that have coronary disorders, they will tell you that nitroglycerin may relieve the pain, but also non-cardiac smooth muscle spasms, such as esophageal or biliary disorder. Even though the best treatment for this, any type of spasm of the vasculature is best treated with calcium channel blocker, patients would have relief with nitroglycerin because it's a vasodilator. Although they don't have any coronary artery disease presentation. Several testing for adults with acute chest pain to rule out life-threatening situations could include pulse oximetry, EKG, chest x-ray, troponin levels should be measured, and a serial is actually best documented by research that is more specific. D-dimer, brain natriuretic peptide, LDH, as well as myoglobin. Cardiac markers or biomarkers measured to evaluate heart function. They are often discussed in the context of myocardial infarction, but other conditions can lead to an elevation in cardiac markers as well. Cardiac troponin testing is an essential component of the diagnostic workup and management of acute coronary syndrome. Cardiac troponins are uniquely to the heart muscle. They're highly concentrated in cardiomyocytes. They're released with very small areas of myocardial damage as early as 1 to 3 hours post-injury, and they return to normal 14 to 15 days after. Cardiac troponin T and I, even more, are the most specific and sensitive laboratory markers of myocardial cell injury, and therefore have replaced already creatinine kinase isoenzyme MB as the gold standard test for acute coronary syndrome. According to the new definition of acute myocardial infarction, was based on elevation of cardiac troponins in blood in the setting of ischemia. The compelling clinical values of troponin resides in its superior prognostic potential in predicting the outcome of patients presenting with symptoms of unstable angina. This is the reason why the American Heart Association, American College of Cardiology, and even the guidelines of European Society of Cardiology Task Force report on acute coronary syndrome with or without elevation of ST segment have attributed troponin measurement as a central role in diagnostic workup and therapeutic decision making for patients that have acute coronary syndrome. It is very important to do a serial test on admission and again 6 to 12 hours. This provides a very risk stratification that even previously used algorithm based on EKG and CK&B. The test results should be available within 30 to 60 minutes because elevated troponins are helpful in identifying the patients who benefit most for early invasive strategies, such as even coronary artery bypass or going to cardiac cath or having a stress test or deciding who to take to coronary angiography and stent placement. So basically, it would tell you decision between medical management, surgical management, taking the patient as soon as possible to the cardiac lab, to the cardiac cath lab. Troponins elevation are mostly, but not necessarily always, related to ischemia um, or cell injury in the setting of acute coronary syndrome. They may also be elevated in renal disease as well as trauma patients. There is an unexplained elevation of troponins that might raise confusion in some practitioners. The majority reflect irreversible myocardial infarction and necrosis. Some patients have myocarditis, pulmonary embolism, acute heart failure, septic shock, even as a result of cardiotoxic drugs or therapeutic procedures such as coronary angioplasty, ablation therapy, cardioversion, would give you also abnormal values of troponins. In the emergency room scenario, pulmonary embolism represents the most important differential diagnosis associated with an elevated troponin level. Because remember, pulmonary embolism would increase the pulmonary pressure at the level of the pulmonary artery, and the pulmonary artery is located in the right ventricle. This will produce an acute distension of the ventricle, not only elevating the BNP, but also damaging the myocytes. So patients with right ventricular failure as a product of pulmonary embolism acutely will present with elevated troponins, and this is called cor pulmonale. CPK is still used to diagnose specific injury to the myocardium and muscle. Isoenzymes that are present for CK and B are the BB, the MB, and the MM. Remember that CKMB is the most specific of the CK enzymes. In addition to the CKMB, other biomarkers will be elevated, such as serum glutamine transaminase, even though you think it's only related to the liver. Sometimes they're elevated in skeletal muscle damage. Patients with cardiogenic shock or even hypovolemic or septic shock would have elevated of this type of isoenzyme due to ischemia to the muscle. It shows an elevation 8 to 12 hours after the infarction, and even though, as I said, it's mostly present for pancreatitis, liver diseases, it could show temporary elevation with myocardial infarction as well. Demedolamorphine also could elevate liver enzymes, so it could be a misleading interpretation. Patients with IM injection as well could have elevation of ASTs, and there's nothing wrong with myocardial infarction. As we explained, creatine phosphokinase is found in higher concentration in the heart, but it's also present in other skeletal muscles. So if you have trauma, it could be elevated as well. It's reliable for inflammatory muscle diseases as well. So Guillain-Barré, myasthenia gravis, patients with multiple trauma, rhabdomyolysis would have elevation of CK and B. Muscular dystrophy, other CNS disorders would also elevate CK and B. We discussed already the different isoenzymes. For example, the MM is present in skeletal muscles and cardiac. The CKMB, BB, it will be mostly in brain, GI, and GU. but the MB is the more definitive marker for myocardial cell damage. And this one rises between 4 to 6 hours after an MI and normalizes 24 to 36 hours after. Before going to BNP, let's talk about myoglobin. This is a blood chemistry used to measure the amount of this enzyme in blood. It's not considered a cardiac enzyme, but myoglobin with elevation of cardiac enzymes. What I'm trying to say is that if you have myoglobin being elevated and at the same time you have troponins and CK and B elevated, it would help you to confirm the results that this elevation is due to myocardial damage. It's an oxygen binding muscle protein. It's similar to hemoglobin. Myoglobin is normally found in skeletal muscle as well as cardiac muscle, and is released into the bloodstream after muscle injury. It helps to estimate the amount of muscle damage. However, because myoglobin does not indicate the site of the damage, this test is only used to confirm other tests such as CK, CKMB, troponins. It is though unique when you're trying to think about patients that have rhabdomyolysis, polymyositis, dermatomyositis, skeletal muscle damage in patients that have systemic lupus, shock, and even severe renal failure produced by rhabdomyolysis. Patients that have cardioversion should not have levels of myoglobin. It would be severely elevated and it would be misleading. Lastly, brain natriuretic peptide is an intracellular enzyme present in nearly all metabolizing cells. Is located in the heart, skeletal muscle, liver, kidney, brain, erythrocytes, you can name it. LDH, this is lactic dehydrogenase, catalyzes the reversible conversion of lactic acid into pyruvic acid. If you remember in pathophysiology in the Krebs cycle, it's an essential step in the metabolic process that ultimately produces ATP, which is energy. Because LDH is present in almost all body tissue, cellular damage increases total serum LDH, limiting the diagnostic usefulness of this test. The beauty of LDH is that if you want to know the prognosis of this patient, if LDH is elevated, means that the Krebs cycle is deviating from aerobic to anaerobic. So the prognosis is very poor. And you should be approaching the family members to tell them that the patient is in shock and is using last reserve to be able to oxygenate the body. For example, in patients that are septic, not only they have severe sepsis, but they're already in septic shock. LDH is also used to see, I mean, if the LDH level is decreasing, you could tell that the patient is recovering. You don't know how much patient will be recovering completely if they will survive or not, but having decreasing levels of LDH after the first rise will tell you that there is a direct relationship to a better prognosis. Because many common diseases increase total LDH, an isoenzyme could also be could be done. There are many isoenzymes. Hospitals don't do ratios or anything like that. But LDH could be present in acute MI, granulocyte leukemia, septic shock, platelet disorders, for very severe prognosis. So again, these enzymes is important to gather detailed patient history and prognosis. For patients that have, for example, trauma, cancer, leukemia, shock, heat stroke, sickle cell diseases, hepatitis, pancreatitis. So if there's a high level at the beginning, it's a very high severity disease and poor prognosis, and decreasing also as well will tell you that the patient is recuperating. Now, brain natriuretic peptide measures the amount of this hormone in blood. High levels are found in heart failure. But not only it's related to heart failure. Remember that BNP and pro-BNP is no more than stretching of the ventricles. It could be the left ventricle, it could be the right ventricle. So patients that have any acute dilation or hypertrophy of the ventricles by either a chronic etiology or an acute etiology could have an elevation of brain natriuretic peptide. Because there is an isoenzyme also at the level of the brain. Patients with CNS conditions would also have elevated BNP. Heart-wise, any acute stretching of the ventricle could be dilated cardiomyopathy, congenital conditions such as hypertrophic cardiomyopathies, aortic stenosis, any acute rupture of the cord tendina, right ventricle acutely could be an acute pulmonary emboli that increases the pressure in the right ventricle due to high pressure of the pulmonary artery. But also chronic conditions such as any type of pulmonary disease could also give you a pro-BNP elevated. Patients that have pulmonary fibrosis, long-term COPD and emphysema, cystic fibrosis due to the thickening of the secretions could give you as well an elevated BNP. It could be used as a screening also and prognosis, as well as LDH. But it does lack specificity, even though many practitioners, as soon as they see an elevated BNP, they think about heart failure. Is only 90% sensitivity, and specificity is like 76% only. Thank you for your attendance, and this is the end of cardiac biomarker interpretation and differential diagnosis of chest pain.